co-hosted by the Infinite Project. I'm the manager of the Infinite Project, and by the Education Program for Health Informatics Professionals. The director of that program is Dominic Covey, sitting in the front seat here. The Infinite Project initiated a Smart Community seminar series 2 years ago, and that series was to explore the impact of information technology and communications on the community, how we work, play, live. And this particular seminar series is going to focus specifically on the value of information technology in our healthcare system. Just to give you an idea of what we're going to be doing over the next hour and a bit, we're going to begin with a special presentation to our new community partner. This will be followed by the seminar presentation, and we will conclude with a moderated discussion. But first, let's do the fun part. We'd like to have a very special presentation. May I introduce to you David Johnston, President of the University of Waterloo, and also host of this seminar series. David, will you do the honors?
I will. Will Patricia come forward, please? This is Patricia Beretta. Patricia is with Mitra. Eric Peterson, the CEO of Mitra, is unavailable today. Patricia is standing in for Eric in recognition of Mitra's great partnership with this enterprise, Patricia, and the $150,000 contribution to provide a series of war, as Napoleon would say. We'd like to recognize that partnership and that contribution and give you a small memento of our appreciation. This is a painting that we think Eric will like especially, and we hope it will find a place in Mitra. It's to Mitra and the University of Waterloo Partners in Creating the Future, and it's a painting of the West Montrose Covered Bridge by an artist named Williams. And after Shirley had made arrangements to purchase this painting, she learned that Eric, in fact, already has a print or another painting from the same artist of a different scene, so this will make a lovely pair. So we present this to you with our great respect and our gratitude for your participation in this important partnership. Thank you.
Well, and I would like to thank you for this is very important to us, and I think that information technology has to the education and the the company is very proud of it. And a symbol of the bridge.
Thank you. A bridge. Well said.
And then we said these bridges covered, which is very good for today.
Well, I'd personally like to thank Mitra for their wonderful donation. It will really help with launching our education program for health informatics professionals. So thank you very much. The whole Mitra row here, and I think there's a few others. Thank you. Before we introduce our speaker, let me give you some background on this seminar series. This series examines both the reality and the dream of using information technology to make our health system both more efficient and effective. We've constructed this series using the metaphor of the patient care process. So this first seminar series, or this first seminar, is going to describe the patient, the health system, and how it depends on information and information technology. Succeeding sessions will examine our patient, the health system, and discover what is wrong, and make a diagnosis regarding information management and utilization in today's health system. In subsequent seminars, we'll look at what we have in our bag of terms of effective treatment, examining the evidence that information technologies can improve the state of the health system. We'll determine a prescription, what needs to be done technically and informationally to improve the health system. From there, we'll formulate a prognosis. What can we expect in terms of improvement in the health system if the prescription is adopted? And we will describe what needs to be done in terms of the follow-up to see if our treatment has worked. After all of that, we'll look at some of the systems that have particular relevance in our region. We very much want to engage each and every one of you, whether you're from the health system, whether you're from industry, whether you're an academic, student. We all want your ideas, your collaborative discussion, and with that we will begin today. So with that brief overview, David, will you please introduce our speakers?
Thank you, Shirley. I'm just delighted to introduce John Oliver and to welcome John and his colleague Jane here to the University of Waterloo to start this important series. John, in welcoming you, I'm going to give you and Jane a little present. It's copies of the report of our Broadband Task Force. The report is entitled The New National Dream of Networking the Nation for Broadband Access. Some of you are familiar with that report, which was released about 3 months ago. And in a nutshell, it says that by 2004, it will be possible for every community in Canada to have a broadband network, and broadband we divide at 1.5 megabytes, which is just barely broadband by some of the definitions. But let's get there with the toe in the door, and then we'll build it up. And the report has a number of recommendations, but the essential one is that the marketplace will probably reach three-quarters of the Canadian population in 1/4 of the Canadian communities by 2004. But if one wants to get the remaining quarter of the population in the remaining three-quarters of the community being defined essentially as a postal office region, one will need some kind of public support to partner with the private sector money. It will have to be public-private enterprise. And the interesting thing is our calculations say that it's a sum of $1.5 billion over a number of years from all levels of government to establish a local pipe access point into the community in which we can build the connections. And by and large, the reaction to that has been quite divided. Those who say that's an appropriate kind of public investment, and others more, do I say, right, impressed with the Globe and the National Post are quite opposed on the basis of let the marketplace do it. And I think that's the major question. Is there a role for public investment in broadband access for all communities in the country? And I would argue strongly that it is. That's where the debate takes place. And to apply it to what John is going to talk about today, just think about the public investment we make in healthcare. At the present time, it's $80 billion a year of taxpayers' money. And just think if one took 1% of that $80 billion, which is $800 million, and if you took a portion of that and invested it in broadband access for the three-quarters of Canadian communities that currently don't have it, and from that you would have interactive digital exchange of information, be it sophisticated x-rays and other images, be it a specialist in an urban center dealing with a medical practitioner or perhaps a nurse practitioner in a remote community looking into the particular diagnosis of the patient, etc., with that degree of activity. The savings alone in that expenditure of $80 billion would more than justify the investment in broadband access to every community in Canada. And that's just looking at one category, health care. Nothing to do with education, which has great benefits that come by way of public investment in broadband access, e-commerce, etc., etc. So, just to say that I'm looking forward so much, John, to your presentation today. I'm so glad that as the first of the presentations in this series we focus on healthcare because it lends itself, I think, so importantly to what information technology can bring, and this university should become the center of the debate. John is the CEO of Home and Healthcare Services Corporation. Has a wonderful background for this. He's doubly credentialed. He's a CA, a chartered accountant, commerce grad from McMaster University. He's a certified health executive with a master's degree from the University of Toronto. Again, illustrating the importance of integrators in our challenging modern life. We need to be able to bring together the expertise of different disciplines if we're going to deal with the most complicated, challenging problems as he is. A wonderful background in this area. He has been the president and CEO of several hospitals in Oakville and Milton. He, in fact, served a period of time that I only learned about today in my hometown at the Plummer Memorial Hospital. John, I grew up in Sault Ste. Marie. I was in the emergency awarded that hospital many times, with stitches, etc. And I think I was very well served by it. My brother-in-law, in fact, was chair of the board, perhaps just after you were there, so wonderful connections. He served as Assistant Deputy Minister in the Ministry of Health, Long-Term Care here in Ontario. He had probably the most difficult portfolio in the ministry at that time, one of the most difficult portfolios that we've seen on restructuring projects as our healthcare system in Ontario is going through these enormous challenges of reorganizing, etc. And is the past chair of the Ontario Hospital Association Information Technology Committee, which really has been a lead player in attempting to do bold and important initiatives and bringing information technology to Ontario. John, we welcome you. I can't think of a better person to start our series.
Thank you very much. And I'm pleased to be here, and it's quite an honor to be invited to be one of the speakers at these sessions. Just to be clear, in my case, I'm a chartered accountant, CA. CA stands for Can't Add for me, so I don't know if I'm an integrator or just someone that recognized I wasn't in the right thing and switched careers a bit. I am going to be, as you can see on this head screen, my focus is from a hospital perspective. Healthcare is about a lot more than hospitals. It's about doctors and patients and lots of other providers. But the only reason I have any credibility or authority, I guess, to speak today is because of the work we've been doing with the Ontario Hospital Association on the development of e-health, and I'll talk a little bit about and unbundle that a bit for you in the presentation. So it's a little hospital-centric, and just accept that. But the issues that we're dealing with in the hospital industry and the systems that we are interfacing with around the hospitals are very similar to what every other sector in healthcare is dealing with. So I think it migrates well into other areas. Is my voice carrying all right at the back? Everybody can hear me fine? A little louder? Okay, let me adjust this. The material that I'm going to be presenting in the slides is from the committee work that we did, and it's advocacy, and it's the official position of the Ontario Hospital Association as it was developed it's about 2 months old now, so it's quite current. I'll also add my own thoughts and comments as a hospital CEO. I just want to say for anybody else who's from hospitals or healthcare, my personal opinions are not authoritative, and I'm quite willing to have them challenged or whatnot. There's many different perspectives in our industry as to the right directions. And the final thing I'd say in introduction, communication is difficult. I'm a hospital CEO. I have a lot of lingo and acronyms and language that relates to hospitals, and you may not understand them. So if I'm off somewhere talking about something and you haven't got a clue what it is because I've used an acronym or something and you don't know what it means, please stop me and I'll let you know what it's about. It reminds me of a bit of a story. There was a guy out, he's driving down a back road, and he saw this sort of kerfuffle in the ditch as he was driving along, and so he pulled over to see what it was, and there were these 3 little penguins that were kind of stumbling and falling along down the ditch. So he got down the ditch, and he sort of herded them up out of there, and he got them into the back seat of his car and headed back into town and realized he was running a bit low in gas. So he pulled into a full-service gas station, and the gas attendant was there and pumping up the car, and he looked in the back seat, and there's these 3 penguins sitting there. So he thought that was kind of curious, so he went up to the driver and said, "Sir, noticed you got these 3 penguins. What are you doing with them?" So the guy went through the story of how he found them, and he said, I really don't know what I'm going to do with them. And the gas attendant thought for a bit, and he said, "Well, why don't you take them to the zoo?" And the guy said, "Great idea," and left the garage away he went. Week later, same car pulls into the garage, and the same gas attendant happens to be there, and it's pumping gas. He looks in the back seat, and geez, there's the 3 penguins again. Only this time they got little towels over their flipper, and they got sunglasses on. And he looks at them, and says, "That's odd." So he goes up to the driver, and he says, "Sir, I thought you were going to take these penguins to the zoo, and I see you still got them." And the driver said, "Well, I did, and we had so much fun. Today we're going to the beach." So communication's not easy. So please stop me if you're not following me. What I'm going to cover off is the current state of information technology in hospitals. And I don't know whether this was coy or not, but we began as an IT committee, and so much of what we're talking about is really communication. It's how to move data, how to communicate data, patient information. So we called ourselves the Information Communications Technology Committee. I'll talk about ICT in hospitals a bit and some of the information that we gathered. A little tiny bit about the committee and why and how it was structured, and then the recommendations that we had from that, and then any time for questions, and then that'll be it. So in terms of the current state of information in hospitals, there's sort of three broad categories of hospitals right now in the province. There are those who were not affected by restructuring, so they weren't amalgamated and turned into multi-site entities. They're still standalone one-of hospitals. And they are very aggressively working, most of them, to move from being a paper-based sort of institution into having more of an electronic medical record and broader use of information technology. For the most part, hospitals today are like banking 15 years ago. If you remember for those of you who are of the age, you'd go into the bank and you'd slip your book underneath the little wicket and your money, and the person would take it and write the deposit and the new balance and initial it, and you get your book back. And you know how you bank today. Very, very different. We're still paper. For any group outside of the hospital, a patient that wants to see their record, a doctor that wants to see their record, it's all paper-based transactions. An enormous number of paper-based. The example I gave in my little shop in Oakville, we have something like 250,000 outpatient visits a year, all kicking out paper, and we have somewhere in the neighborhood of 15,000 patient days a year. And one day in the hospital produces, a volume of paper. So it's an enormous paper industry. So some hospitals are standalone, and they're really working on putting in their core functionality that they need to begin to bring information up into that electronic kind of medical record. Other hospitals were amalgamated, and they're busy right now trying to network. They're trying to find ways to communicate across their sites so that they can function, with one general ledger, just trying to manage the communication and issues that multi-site management brings to them. The third group are the ones that have really progressed quite well, and they've developed that internal, their internal functionality is there. They have an electronic medical record, and they're actually out experimenting in communicating with the doctor's offices and communicating with home care agencies and others out there. I can count on one hand the number of hospitals that have reached that point, that have actually bridged their organizations and are actually interfacing with doctors. So for the most part, as it says here, in information intensive, a lot of local solutions being built, particularly as hospitals experiment with communication outside of their own four walls. There's limited connectivity or ways and means to move patient information in and around the hospital with confidence and external to it, and a lot of other issues in terms of where they're at. There's also a focus in hospitals more on departmental solutions than on that sort of a central vision of how we get consolidated patient information. Hospitals are very political, like a lot of organizations, and there's strong doctor lobbies, there's strong specialist lobbies and invested interests in them. So there are a number of other areas that hospitals are, I'd almost call it tinkering and playing with things, although some would argue that it's more than that. That's one of my personal commentaries. So we're looking at supply management systems, supply line management. We're looking at how to integrate payroll systems with human resource systems and how to have better human resource transactions. Emergency tracking boards are all the rage right now, and enormous money is going into tracking patients just through the emerge part of the hospital. All of us are investing heavily in websites right now, so we're using them mostly for advertising, promotion issues, and staff recruitment. Although you're seeing a little bit more of websites being geared towards patient interface, so sort of dialing up and booking appointments and whatnot. So for the most part, there's a lot of that kind of investment still happening, but it's focusing time and attention away from some of that core functionality. And what I'll talk about in here and cover off is the need for the industry and the need for the system to begin to get a vision. There is an enormous capital investment required to move hospitals, to move the health system forward, an enormous capital investment in the hundreds of millions. And part of the struggle we have and will have in our industry is to stay focused on what's important to the consumer and put the investment in some of those other sort of specialty areas off until we are able to produce a more comprehensive patient system. So just a little bit then about where we are. This was a survey that was done. And it looked at how much Ontario healthcare spends in total on capital and operating dollars on information systems. So we're down here at the bottom at 1.7%. You can see globally, hospitals, US, Europe, Japan, sitting at about 4.2% of their total expenditures devoted to it. It's worrisome to me that we are, as a information-intense service industry, that we invest on par with the raw material extraction industry. So petroleum and pulp and paper invest roughly at the same pace and rate that we do. So there is an issue. I mean, we aren't progressed as an industry, but nor have we put the dollars or the investment into it. In terms of the projection, and this part of our committee work was surveying the industry, so where do you see expenditures going for you when we aggregated those across the province? So capital continues to be probably it was the major investment in earlier years. Now we're seeing more and more operating dollars dedicated to and planned to be dedicated to ICT investment, and training beginning to increase. A good example in our place, we're now at a point where we have an electronic medical record that is available. We've been training nurses and doctors onto it, and you get these odd hybrid situations when you're in transition. So we have some very young medical staff who've just come from universities and are very computer literate. And, you know, what do you mean you just got this? You know, I've been working on one for years kind of thing. And we have nurses who still don't know how to use them. So the docs are in putting their orders and consult directions and whatnot in on the electronic record, and the nurse is still looking for the paper record, for the paper order, the paper consult. And as a result, you get these real juxtapositions and worries around care. So the need for training and the need to move an aging nursing workforce forward is a real issue for us, and that's part of the training requirements. In terms of where the hospitals are intending to put those investments, and you can see what I talked about the competing interests inside the organization. So for the electronic medical record, which is really what will bring patient information up out of the bowels of the hospital and make it available for outside agencies, is the red diamond line. And finally, it's beginning to receive the sort of recognition and approaches that it needs. Regional networking is still a big issue post-restructuring, and there's been enormous infrastructure spent on allowing hospitals to talk to one another. And then a number of other competing interests. PACS is a picture archiving computer system for radiology, so a very departmentally focused program. Video conferencing, so it's fairly limited. And this gives you some idea of where the investments are by type of hospital. So if you're in the private sector and you're wondering where to put your time and energy, it's in community hospitals. The teaching hospitals sort of feel their investments are matured, and they're just going to continue on with that level. It's the community centers that are really seeing and feeling the pressure for increased investment. And then we asked what they felt the barriers were to addressing organizational ICT issues in terms of moving forward. And this is internal to the hospitals. Funding is the number one issue, and I'll come back to some of the cost estimates. We don't have the human resources in healthcare, certainly not in hospitals. So we don't have the IT people who understand health and who understand the possibilities of what can be done with the information systems available to us. Consensus building inside the organization about where to put resources and how to use them is a problem. So it's, again, that vision issue. Isolation. Hospitals tend to function and live alone in their own shops. So how do you get best of breed? How do you get benchmark performances? And finally, just knowledge of what's happening in information communication technology. What's the new state of the art? What's going to be possible in 5 years? That knowledge doesn't exist in the industry. So from that, the OHA decided, from that sort of history, the OHA decided to form this Information Communications Committee. It really is an advocacy committee, and you'll see that a lot of the positions that have come out of it are not sort of matter-of-fact, do this, do this, do this. They are positions that were created to try to influence government and influence all the individual hospitals to begin to move forward around a common vision and around some common issues. And this committee was advisory to the OHA on that. And we had very broad representation. We had more private sector and participants from government and other providers than we did from hospitals. Thank goodness, because that allowed us to get out of the same old saws and the same old sort of rhetoric, and we got to some new areas. The committee was, we did two things. The first was the policy paper and recommendations, which is the part I was chairing, and that's wrapped up, and what I'm presenting to you today are the policy paper recommendations. And the policy paper is available on the OHA website if you want to read the entire document. And then from there, I'll go into the recommendations. The one thing we realized as a committee was that if there was just so many issues and so many pressures and so many different directions, both from the private sector and the institutional sector perspectives, that we had to have a common vision and that we needed something to say, this is what we're going to root our work in, our research, and base our recommendations on. So what is that common vision? And this is, in my mind, what the e-health definition is today for us in our industry. So, and it comes from the Health Services Restructuring Commission. If you remember those guys, they're the ones that went around the hospital, went around the province closing hospitals and doing all kinds of terrible things. Once they'd done all that work, they actually spent about 6 months working on what's needed to move the system, and they did a very good job in articulating what was needed in terms of health information, in terms of the health system. So looking for an integrated health information network with an electronic consumer record at its core. And there's privacy issues, absolutely paramount in that, and confidentiality, but real-time capture and movement of data so that a decision maker has real-time access to data from a hospital, from a pharmacy, from a doctor's office, from whatever the healthcare provider is. That information has to be available. And there's personal comment. To my mind, this isn't a huge spectrum of decision makers or a huge sort of array of moments in time when you need this data. If you think about it yourself, we're all health consumers. You've all used the health system. It's needed in the emergency room. So if you arrive in the emergency room, particularly if you're confused, if you've had some kind of trauma and you can't, or if you've been brought in by ambulance and are unconscious or not functioning, you can't communicate what's happened to you. So odds are, for most people coming into the emergency, if it's not trauma, it's the culmination of something that's been happening already. So they've probably been to their family doctor, they probably had some tests, some lab work done. The family doctor probably has a pretty good idea in his or her office about what's really wrong with the person. They're probably on a bunch of meds, and most people that use the system are elderly, so there's probably a number of medications that they're already on. And there's an underlying health condition that has sort of manifested and caused this, the emerge visit. So probably everything that the emerge doc needs to deal with that patient is out there somewhere in the system. It's just not available to them. So they start cold, going through the elderly woman's purse, trying to find what meds that they're on. So they know if they do give them some meds, they're not going to have any complications or there's no contraindications. If they're waiting for lab results, the lab, which can be quite a time-consuming turnaround, they're probably already done in there in the system. So the emergency is one place where access to all available health information that's relevant is important. The doctor's office is another place. Physicians are trying to minimize, to be fair to them because of their own funding, the amount of time that they spend with a patient. I mean, they're not there to spend a day with one patient. So what information is needed for the physician from the hospital, from other agencies? That's probably an important point. And the pharmacist. The pharmacist needs to know what other medications you're on, what allergies you have, what complications you have, so that if they follow the doctor's script and the doctor's missed it, They are your last safeguard against pharmaceutical complications. So there's a few other areas, but those are probably the key ones. And then the rest of the points here that the HSRC came up with cover off some of the sort of broader ranges of that network. So it's consumer-oriented. It's there to help the provider deliver better quality, affordable health care. It's the healthcare system managers can start to draw information about the system and in terms of quality and accessibility and how to use it better. And the government and the payers are going to have better information in terms of resource allocation. So if we're going to be moving towards that vision, and this is sort of part of articulating and lobbying to individual hospitals, these are the kind of directions that hospitals should be focusing on. So we need as a system to have a secure network external to the hospital that allows information to be moved from our door to the doctor's door to the some other emerged department's door. We need consistent standards, and I'll come back to these points a bit later. We need internally to get to electronic patient records so that we can put data out there once whatever that network is comes to our door. And we need to have a common patient identifier, and I'll come back to that. And some of the barriers, I talked about barriers to moving forward with the organization. These are the barriers that we found from our surveying in terms of moving forward with that systems-wide vision for eHealth. The big one is there's no common standards out there. So the doctor's office is collecting his information in his own way, in his particular data file, that may not in any way be able to communicate, be able to relate to the hospital, electronic medical record with data collected in its own way, in its own particular, sort of data file and base. So there's no common standards, and there's no understanding yet of the connectivity standards. So if there is a net, a private health net created in Ontario to allow information movement, there's no standards around how that will be created. So that if we're in my shop creating an electronic record, I don't know what we need to do to be able to get that out and moving on the net. The shared vision is not there. The Restructuring Commission vision has been very poorly circulated and agreed to. Leadership. Surprisingly, the barriers in the hospital, the biggest barrier was resources. Cost of systems solutions is not as big a barrier as those leadership and broader perspectives. And once again, knowledge within the health system. There's just not the people, there's not the human resource that understands and knows how to work with these issues. And I think I've covered these off. So in terms of the recommended areas that we came up to, we broke them into 3 categories. So the first is dealing with the infrastructure. So the first is we need in the province to develop or maintain a common patient identifier that all providers use. So whether it be one number, and you would think logically everybody has a health card number, why wouldn't that be the patient identifier? That's not the case. Every single organization has their own unique identifier for patients. So how do we get to an agreement on a common patient identifier, or if not that, then some kind of systems, or again, I'm not a program, but some way to translate all those different unique identifiers around one common number. Without that, you can't fundamentally move information that's relevant to a consumer, and you can't get the right information in the hands of the providers. We need to implement smart systems for health, and this is probably one of the most controversial issues in these recommendations. Let me just get to that. Smart systems for health, and I'll come to another slide on it, but just to describe it, because that's a title. This is basically this is the information highway. It's a private health net that would be developed in Ontario. So this is the vehicle that would allow my hospital's records and the doctor's records and the pharmacy records and whomever is using them. This is the vehicle that will allow the movement from all those different portals to the receiving decision makers and to the consumer that wants that information. And Smart Systems is the current Ministry of Health, Government of Ontario title for that health network. We need personal privacy legislation introduced really quickly. I mean, as if you could picture yourself, if you think about the information that your doctor has about you, or the information that your local hospital may have about you, you'll want that moving freely along some provincially run health network being used and utilized by unknown different people. So right now the personal privacy legislation is not strong, and there's also barriers in existing legislation to actually allowing information to move. So I'm right now restricted as a hospital CEO from letting any patient information leave our building without that assigned consent. And there's a good chance that the person that wants that information being used by their family doctor or is in the emergency department will not have time to come in and sign the consent to get the information released when they want it to go. So we need some very thoughtful, some real thought on how we're going to handle the movement of health information outside of the providers that you already, through your provider relationship, are dealing with. We need common data standards, as I said, in terms of both connectivity and the content of data. And for hospitals, and this comes back to sort of the hospital-centric stuff, every hospital is at a different state of development and is putting resources into all kinds of different interests of their local area. We need to develop a standardized hospital functionality so that we can participate fully in the smart system when it comes. In terms of the strategies for managing the change, and I'm going to focus again on smart systems, this is, there's about $500 million that was allocated in the last budget to smart systems to develop this health information network. As it sits right now, it's a government agency and it functions under the ministry, a couple of the ministries. And with that, you have the risk of whatever the political agenda of the day is, driving and shaping that particular health network. And this is something that, if it's going to work, needs to continue well past the term of any government. It has to continue well into sort of a decade of development. And for any one government to actually sit with it and carry through the initiatives of other governments is always very risky. And it's also, as my own personal experience, that anything that sits in government is at risk of the agenda of the day driving it, and just the local minister, the local minister's office shaping and influencing something as important as how our health information would move in the province, I personally feel is quite risky. The current thinking within government is to create an agency, so a quasi-arm's length vehicle, would have its own board and its own mandate to house smart systems, and that would be the group that actually develops and works on this. And I won't go into much here. We have quite a bit of advocacy work done with the OHA. There's 3 or 4 kinds of agencies that the government can create. Some are really close to government, and some are really far away and have very, very loose threads of control. And we're certainly promoting that they create smart systems, that agency, as far away as they can get from any kind of political influence. And then finally, the Ontario Hospital, just as an industry, we've created an e-health council, and that's sort of the offshoot of this committee that I was chairing. And there's now, again, is drawn from hospitals, other stakeholders. It's not quite as broad-based a collection of people. And that's to advise smart systems and to really begin to promote hospital issues and also systems issues within the ministry, within smart systems, and across the hospital membership in Ontario. We also realize that the smart systems group really don't understand health, and this comes back to that marriage of people who understand technology with people that understand health. So we are advocating with all of our sister providers, so the Ontario Medical Association, the home care agencies, pharmacies, private labs, anyone who's out there as a provider, to come together to form a provincial ICT sort of coordinating body. Again, to make sure that we have the right thinking and the right thought process from a care delivery perspective within the smart systems environment. And the OHA is creating the position of a chief e-health strategist, so somebody who can help steer our industry right now to get away from all those individual shops and individual board CEO decisions to try to create a more comprehensive strategy. And then finally, education. There is, as I said, a lack of understanding of what's possible in technology. I mean, in this room, there is probably more knowledge and understanding of what's possible than across, a good chunk of the hospitals in the province, because it's just not part of the skill sets that we've developed, hired, trained people in. So we're beginning a fairly extensive education cycle for hospitals. Just the last couple of slides. Cost is a huge issue, as I mentioned. These are some of the estimates, not just for hospitals, but of the development of a health network and bringing all the different providers onto that network. So there was a 1999 Enterprise Canada survey that put it as a 5-year project at $1.5 billion. Sorry, that was just hospitals. The Canadian Hospital Association was $4.1 billion for the system. In terms of our survey, it was $1.2 billion just for hospitals. And I won't go through them all, but the estimates of the system are in the $3 to $4 kind of billion range. So it's not, and where and how we find the finances for that in Ontario, quite frankly, is unknown. If you think about your bank, the way the banks afford to move from paper to your current banking arrangements is user fees. So you pay per transaction, you pay $1 or 35 cents or whatever it is per transaction. Do we need to look at a transactional fee or some kind of systems, ICT user systems fee to finance the development of the technology? Or, as it was said, health is an $80 billion budget. Can we take 1% a year for 5 years and really work on how we move information? The point I was making about there's a limited number of places where the consolidated information is needed, and it's really not even consolidated, because in my one hospital chart has thousands and thousands and thousands of bits of information. A doctor in his office from a hospital just needs 2 or 3 pieces of that record, and they need them from the minute the patient walks in the door, and they need to have it ready for them as part of that sort of initial assessment. So how do we, this is just a sort of a quote from MD Everywhere in the USA, and the use of handheld technology that allows a doctor to both download and upload information very quickly in his office with handheld devices. How do we get to that kind of technology in the province? And this is just some of the OHA propaganda on the benefits of e-health. But there's one quote that I wanted to give to you. This is a guy named Joe Flower, who's a futurist and a guy who works with complexity and whatnot in the U.S. And this is his description of the change in healthcare. So healthcare at its base is about a deep ongoing series of connections between the patient, the doctor's colleagues and his or her peers, the hospital, the pharmacy, the vendors, and the patient's family and the patient support network. The whole world of knowledge about health, disease, medicine, and prevention that's all becoming available on the net. All of these connections will become closer, more intimate, deeper, wider, and more easily navigated and searched as we go forward. So how do we then in Ontario prepare ourselves for that kind of change and that kind of direction? And that covers off, show that slide, covers off pretty much what I wanted to say.